this topic is, I think, one of the most important ones. I mean, I could say that for every single one of them, but the Gardasil vaccine came out, I think it's like 10 years ago now. And it is one of the most heavily advertised, has TV advertising with it, and it is maiming our teenage kids. And it started off with girls only, and they now are giving Gardasil to boys too, and to me that's a complete money market piece to it. But there's a lot of information out there, and I really wanted Marcella to talk about HPV. She's the one person, along with Suzanne Humphreys, but Suzanne's already giving 3 talks here, so I couldn't ask her to do another one. So I looked to Marcella and said, could you do something on HPV? Because there's not a body of information. There's a lot of information out there on the HPV vaccine and on human papillomavirus and the virus, and that this vaccine is amazing and it's going to stop cancer. And I feel like the truth needs to get out there, and Marcella's been doing the work behind it. And so I really wanted her to come. She's, if you don't know her, Marcella Piper Terry. She's an independent researcher, journalist, speaker, activist, amazing mom. She's the founder of vaxtruth.org, which she got going in 2011. She's published on there about, I think it's over 100 different or 200 different articles. Amazing website, amazing information. Her sort of start to all of this was her daughter got injured by her kindergarten shots, and that sort of threw her into this world. She's also the co-conspirator, I'm going to say, in the CDC Truth rallies with Michelle Ford. They do an amazing job of getting the knowledge out there in these rallies. So I'm so honored to have you, Marcella, and thank you for coming to sort of not quite wrap up, but nearly wrap up the day. Thank you.
Okay, I'm really glad to be here, and I'm really thrilled to be the opening act for Suzanne Humphreys, who's coming after me. And I did poach some of her stuff. You'll see it in this talk. So I'm just going to run through this because there's a lot of information. This talk is going to be more of an overview, but I think there'll be some new information, and I hope that everyone here will learn something. Okay, so I'm just going to start with the human papillomaviruses. What are they? They're a group of more than 200 related viruses. It used to be they'd say there was more than 100, and then they said there was more than 170, and now they're up to more than 200. So we really, that tells us we don't know how many there really are. More than 40 types of HPV can be spread through direct sexual contact, and that's vaginal, anal, oral, or skin to skin. It does not have to be intercourse. Sexually transmitted HPV viruses are classified as low risk or high risk, and the low risk HPV types are associated with warts and upper respiratory infections, and there are at least 15 to 18 high risk HPV types that are associated with certain cancers. Now, I want you to notice, okay, I'm saying associated, right? There's a difference between associated and causal, just as we all know. And the high-risk HPV types that are associated with cancers are cervical cancer. The cancers are cervical cancer, anal cancer, and vaginal and vulvar cancers. And the sources for this information are the National Cancer Institute and the CDC. So, how prevalent is HPV infection? It is the most commonly sexually transmitted type of infections in the United States, with 14 million newly acquired genital HPV infections each year in the U.S. And 80 to 90% of all sexually active women and men will acquire at least one HPV infection during their lifetime. There are about 12,900 new cases of cervical cancer annually in the United States, which represents 0.76%, so less than 1%, out of the approximately 1,685,000 new cancer cases of all types diagnosed. The majority of women clear the HPV virus from their bodies naturally within 6 to 18 months of infection. Women with risk factors such as HIV infection, smoking, long-term use of oral contraceptives, and co-infection with herpes simplex virus or chlamydia are at higher risk for chronic HPV infection. That's an important thing to remember, is that if you have other sexually transmitted diseases, it increases the risk of chronic HPV infection. So early onset of sexual activity and higher number of sexual partners increases the risk of chronic HPV infection. And chronic, again, we want to make sure we're talking about not just HPV infections, but chronic HPV infection is associated with precancerous changes in the cervix, which can progress, not always, but can progress to cervical cancer if left undiagnosed and untreated. So let's just take a breath and get a little perspective. So according to NIH and the CDC, there are 14 million new genital HPV cases each year in the United States. And there are 12,900 new cases of cervical cancer each year in the U.S. So I did my little math stuff and use the percentage calculator, and I said, so what is, 12,900 is what percent of 14 million? And we came up with 0.09%, and that translates to a case ratio of 1 in 9,000. And that means about one case out of every 9,000 new cases of HPV infection is associated with cervical cancer. And that also means that the other 8,999 new cases of HPV infection are not associated with cervical cancer. So take a deep breath. All right, going back to HPV and cervical cancer. There are about 4,200 deaths in mostly older women in America annually attributed to HPV-related cervical cancer. And that's about 0.7% of the approximately 596,000 cancer deaths that occur in the United States. So less than 1%. Most cervical precancers develop slowly, so nearly all cervical cancers can be prevented with regular pap smear screening and prompt treatment. Survival for women with pre-invasive cervical cancer lesions is nearly 100% with early diagnosis and appropriate treatment. Between 1955 and 1992, cervical cancer deaths in American women dropped by 74% due to routine pap smears. Okay, I can't show this because we have no internet in here and I didn't download it. But what this is a cervical cancer video from the National Cancer Institute. And in that video, they talk about how the incidence of cervical cancer has decreased, not just since 1955, that was the earlier number that was available, but this is a direct quote from that video. A simple pap test can find abnormal cervical cells before they become cancer. As a result of increased screening programs, new diagnosis of cervical cancer decreased by more than 50% overall between 1975 and 2010, and decreased by more than 65% in women over the age of 50 years during that time. Now this is important here. Groups that are still at increased risk include Black women in the South, Hispanic women along the U.S.-Mexican border, white women in Appalachia, Native American women, Asian American women, Alaskan Natives, and Pacific Islanders. And the increased risk is due at least in part to lack of access to screening programs, not lack of a vaccination. This has to do with equality, which is a pretty important thing. Okay, so the HPV vaccines, Cervarix, Gardasil, and Gardasil 9. Cervarix was licensed in 2009 for protection from HPV strains 16 and 18. Gardasil, the quadrivalent, was licensed in 2006 for protection from HPV 6, 11, 16, and 18. And Gardasil 9 was licensed in 2015 for protection from HPV 6, 11, 16, 18, 31, 33, 45, 52, and 58. Gardasil 9 that protects is marketed to protect against 7 high-risk strains and 2 low-risk strains. HPV 6 and 11 are low risk. So it's currently the most widely used in the United States and in many other countries. It's actually the only one that's being produced now in the United States and used. They didn't pull Gardasil quadrivalent from the shelves, so there is probably still some out there, but it's no longer really actively being used. And this is the schedule. And I put this up there because it's kind of confusing to me. And I look at this stuff a lot, and I know a lot of doctors don't really look at this so much, and I know a lot of nurses don't either, because I've been seeing some reports of infants who are getting the HPV vaccine by mistake because they thought it was an HBV vaccine, which is hepatitis B. So infants are being injected incorrectly. So, that kind of gives me a little bit of a pause when I think about how well they're going to be able to interpret this information. So the schedule for Gardasil 9, if you are 9 through 14 years old, you will need 2 shots, as long as the second shot is not given any sooner than 6 months after the first shot. If you give the second shot before 6 months have passed, then you're going to need 3 shots. So it's 2 or 3 depending on how well they follow the schedule. And 15 through 26 years old, then you get 3 shots, with the first shot given 2 months before the second shot, and then the third shot given 6 months after the first shot. So that's kind of a complex schedule, if you ask me. So what's in Gardasil 9? These are the ingredients. Proteins of HPV types that are covered in the vaccine. Amorphous aluminum hydroxyphosphate sulfate, which is known as AAHS, and that is a particular type of aluminum that is used in the Gardasil vaccine. It was trademarked and a secret, Merck secret kind of thing, and Suzanne Humphries has done a really good job of digging down into this scandal about the AAHS aluminum adjuvant, and I have a link for you later, so I'll give you more of that so you can find some more information. Also contains yeast protein, sodium chloride, L-histidine, polysorbate 80. Does anybody know what polysorbate 80 is? Okay, so for those who don't, it's a surfactant. It is used, it's put in the vaccines to keep things from clumping up, but it also kind of strips the biofilm of the gastrointestinal tract and opens up the junctions that are supposed to be tight, not only in the gastrointestinal tract, but in the blood-brain barrier. So it opens up the blood-brain barrier. They actually use polysorbate 80 in cancer drug trials because they can bond it with the medication that they want to get into the brain and the central nervous system, and it'll open up the blood-brain barrier and walk that stuff in. So it's really not a good idea. If you've heard anything about the aluminum talks that Dr. Exley has been giving this weekend, it's just not a real good idea to open up those the blood-brain junction when you're also injecting quite a lot of aluminum. So that's also in there. Sodium borate and water. This is the vaccine information sheet for, the VIS for Gardasil 9. This is a 2-page document. Document is kind of like a tongue-in-cheek thing. It's produced by the CDC, and it's a watered-down version. It's what they want you to know about the vaccine. People are supposed to receive this prior to getting any vaccination in the doctor's office. When you ask your doctor for information about the vaccine, which is what the videos tell you to do, ask your doctor. So you go to your doctor and they give you the vaccine information statement. So that's what anyone would get if they're going in for Gardasil, including, in California, children as young as 11 or 12, who, thanks to AB 499, now can go and request Gardasil from their doctor. So this is what the information they would get. I have 2 things here in my hand, which total together 51 pages. One of them is the manufacturer's insert, the prescribing information for Gardasil, the quadrivalent, and that's 28 pages. And this one is 23 pages, and it's for Gardasil 9, which doesn't make a lot of sense if you know that Gardasil 9 includes more antigens. It includes lots more percentage of certain antigens than Gardasil, the quadrivalent. It includes a lot more aluminum than the first one. And the reason that it's smaller is because they didn't do any real new studies. They said that since Gardasil was generally regarded as safe, GRAS, G-R-A-S, then therefore Gardasil 9 is also safe. So in order to understand the clinical trials and what happened with both of these vaccines, you have to read both because they use this information for this vaccine. And I don't know any 11 or 12-year-olds who could possibly wade through this stuff. Okay. Another video that we're not going to be able to watch, but this is, does anybody in here remember the first Gardasil commercial they came out with, the one that's one less? I'm going to be one less. I'm going to be one less girl with cervical cancer, right? Merck marketed really heavily to young adults and to children, to teenagers, and to their parents. And it was a fear tactic, a fear campaign, and it was about being one less. So now we know what Merck says, and we know what the CDC and the NIH say. So let's talk to Diane Harper. Does anybody in here know who Dr. Diane Harper is? Okay. Diane Harper is an internationally recognized expert on HPV viruses and cancers. She was the lead researcher for Gardasil vaccine trial. She was also a principal investigator for Cervarix. So this was an interview that was published in the Huffington Post in 2010. And the question was asked, can you explain what your role as principal investigator for clinical vaccine trials for Merck and GlaxoSmithKline Cervarix entailed? Principal investigator means that I was responsible for assembling a research team to recruit participants, deliver the health care during the study, collect biological specimens at the correct time, and retain subjects over the entire time frame of the study. After the data collection is complete, I have professional, medical, clinical obligation to review the data for interpretation, comment, and publications. And you can, when you're looking at my slides, if you're taking notes, if you see down on the bottom there, the tinyurl.com/Dr. Harper HuffPo, that's, if you want to read that whole interview, you can go to that tiny URL and it will come up. And you'll see those tinyurl.com/ at the bottom of my slides. Okay, so this is from that interview with Dr. Harper. The question is, the public has identified you as a doctor knowledgeable about HPV and the vaccines, potentially without an agenda. Can you explain what you support about the Gardasil vaccine and what you see as its faults? Gardasil, this is Dr. Harper, Gardasil offers sexually active women who do not currently have HPV 6, 11, 16, or 18 infections protection from genital warts and CIN2+ disease for 5 years. If the vaccinated person is not sexually active during the 5 years of its efficacy, then the vaccine has not protected her from disease, as we do not have evidence that Gardasil offers efficacy any longer than 5 years. Its faults include tiny antibody titers for all HPV types other than HPV 16, limited protection, limited duration of efficacy, and safety concerns, as outlined in her opening statement. The question was asked, do you believe that the Gardasil vaccine as it currently stands could present more risks to a young girl or woman than the possibility of cervical cancer? Pap smears have never killed anyone. Pap smears are an effective screening tool to prevent cervical cancer. Pap smears alone prevent more cervical cancers than the vaccines alone. Gardasil is associated with serious adverse events, including death. If Gardasil is given to 11-year-olds and the vaccine does not last 15 years, then there is no benefit, only risk for the young girl. Vaccinating will not reduce the population incidence of cervical cancer if the woman continues to get Pap screening throughout her life. So she was asked, can you point out specific misstatements that Merck has promulgated about the vaccine, about the Gardasil vaccine? What is left out is that 95% of all HPV infections are cleared spontaneously by the body's immune system. The remaining 5% progress to cancer precursors. Cancer precursors, specifically CIN3, which is cervical intraepithelial neoplasia 3, which is the grade 3, progresses to invasive cancer in the following proportions. 20% of women with CIN3 progress to invasive cancer, cervical cancer, in 5 years. 40% progress to cervical cancer in 30 years. There is ample time to detect and treat the early precancers and early stage cancers for 100% cure. And then down at the bottom, Gardasil is not really a cervical cancer vaccine. The vaccine prevents HPV infection, not the development of cervical cancer. And that's really important. Merck and the CDC and NIH are all claiming that this is a cancer vaccine. And here is the principal investigator stating unequivocally, this is not a cancer vaccine. It prevents HPV infections, and the only HPV infections it prevents are those that are covered in the vaccine. And remember, there are more than 200 different strains. Has the original Gardasil marketing campaign of one less muddled the waters and misinformed the public, who heretofore believed that a pap smear was sufficient to protect them from cervical cancer? This is her answer. If women were participating in pap screening, or if as a parent you educated your daughter to seek pap screening at the appropriate age, 21 years, for her entire life, then she would have been very likely to be at risk for being one and would not be one less. She would not have been one to begin with. The marketing campaign was designed to incite the greatest fear possible in parents so there would be uptake of the vaccine. And another video. This is the Not a Coincidence video. Has anyone seen this? This is a video that was put out by the Canary Party a few years ago. And they interviewed parents of young women who have died after Gardasil vaccine. And they talked to young women themselves who have had severe reactions and are experiencing disabling conditions as a result. And the title of that video, it's very, very well done, but it's Not a Coincidence. And the reason they called it Not a Coincidence has to do with the clinical trials, the Gardasil clinical trials and the safety trials. And I'll tell you about why that's important when we get to it. So this document here is the VRBPAC, I always want to forget the P, background document. The VRBPAC is Vaccines and Related Biological Products Advisory Committee. This is part of the United States Food and Drug Administration, the FDA, and they conduct meetings and they review information submitted by vaccine manufacturers regarding safety and efficacy in clinical trials. So they're reviewing information that is given to them by the vaccine manufacturers who are conducting their own clinical trials, their own safety trials and that kind of stuff. So just to make sure we're clear on that. Now there are some things in here that you might want to understand a little bit more. Virus-like particles is VLP. HPV type 16 and 18 thought to be responsible for more than 50% of cervical cancer. Now that's what the VRBPAC says. In other online information and things put out by Merck and the CDC, they say that 16 and 18 are responsible for virtually all cervical cancer. That was early on. And then they said, well, maybe 70%. And then they said 50%. And then the other thing that we want to talk about is that cervical intraepithelial neoplasia grade 2/3. So over here, what the heck is a virus-like particle, right? And I told Judy I was going to tell you guys this, but there's no way in the world that I would stand up here and attempt to discuss retroviruses and DNA and that kind of stuff in cancer with Judy Mikovits in the room. So if you want to know more about that, either see me privately and I'll BS my way through it, or talk to her because she's the expert. But what this article, you can look up more here as well, that tinyurl.com/HPVVLP. But HPV vaccines based on VLP production by recombinant expression of major capsid antigen L1 in yeast for Gardasil, or insect cells for Cervarix, GlaxoSmithKline, have been licensed for the prevention of cervical and anogenital infection and disease associated with the genotypes targeted by each vaccine. So basically, what you need to know for this is that it's a genetically modified sort of kind of virus, but not really a virus, that was made in a lab. And we'll find out where that took place and all of that in a little bit. CIN is cervical intraepithelial neoplasia 2/3. Abnormal cells are found on the surface of the cervix. Cervical I can't even say that again, is usually caused by certain types of human papillomavirus and is found when a cervical biopsy is done. Cervical intraepithelial neoplasia, grade 2-3, has features of CIN2 and CIN3. It is not cancer, but may become cancer and spread to nearby normal tissue if not treated. That's a really important point because in the clinical trials for Gardasil and for Cervarix, they just kind of went willy-nilly and they said, well, we'll just look at, they didn't look for cancer as the endpoint to see if it actually worked against cancer. They looked for CIN2-3 in some, and they looked for any sign of changes in abnormal cells in other trials. So there wasn't a lot of consistency there. And once again, they did not test for prevention of cancer. Their endpoints were CIN2/3 in most of their trials. Going back to this VRBPAC document, there were some concerns about the information that they were given from Merck about their clinical trials. And two important concerns. The first one was the potential for Gardasil to enhance disease among a subgroup of subjects who had evidence of persistent infection with vaccine-relevant HPV types at baseline. So they said we need to evaluate. Evaluation of the potential of Gardasil to enhance cervical disease in subjects who had evidence of persistent infection with vaccine-relevant HPV types prior to vaccination. So in layman's terms, you have an HPV infection that is one of the types that's covered in the vaccine, and then you go into the clinical trials because they didn't test. I guess some of them they did. In some trials they did, but in others they did not. But they tested to find out. So they wanted to see what's going to happen if they already have these viruses. And what they found was the results of this study suggested a concern that subjects who were seropositive, they were HPV positive for the strains covered in the vaccine, they had a greater number of CIN2/3, those precancerous lesions, or worse, which is pretty concerning, as demonstrated in the following table. And that little box down there, I do have one, don't I? I don't know that I can get it, but you can see it over there on the right. That negative 44.6%. What that means is that women and girls who were already infected with HPV strains covered in the vaccine had a 45% increased incidence of precancerous lesions following vaccination with Gardasil. That's kind of scary, isn't it? Yeah. So, given that vaccination increases the incidence of precancerous lesions in those previously infected with HPV, it is important to determine who is HPV positive prior to vaccination. This is not being done. It has been known since at least 1997, which is when they did the first clinical trials for Gardasil and Cervarix, that HPV can be transmitted from mother to infant. And you can read this study at tinyurl.com/HPV-MOM-BABY. Exposure of an infant to cervical human papillomavirus infection in the mother is common. Now this is from that study. And the objective of the study was to determine the potential of exposure of an infant to cervical human papillomavirus infection of the mother. I'm just going to skip to the conclusion here. Our results indicate that the infant of a human papillomavirus infected mother is exposed to infection even when the cervical infection of the mother is subclinical. The possibility of transplacental exposure has to be considered as well. So they're talking about whether or not you have signs of an active HPV infection in your cervix. Sometimes they may say, well, you have active HPV infection in your cervix, so we're going to deliver the baby by C-section. That's one option. But what they found was that it wasn't, there is evidence that it is actually, that the virus is transmitted in the womb. This is another study. This is from 2005, transmission of high-risk human papillomavirus between parents and infants. And the Finnish HPV family study was designed to evaluate the natural history of HPV infections of the infant as well as the transmission of HPV between the parents and the infant. The present report is focused on the dynamics and risk factors associated with the acquisition of high-risk HPV in infants. Now, who knew that you could give your baby HPV infection even if you didn't know you had it? Because haven't we all been told that it's all about sex? Right? HPV is spread through sexual contact. That's what we hear over and over and over again. Because they're capitalizing on the fear of parents who are concerned about their young children becoming sexually active teenagers, and oh my gosh, we have to protect them. But what they don't realize is they may already be infected, and if they are, then getting that vaccine increases their risk of precancerous lesions or worse by 45%. That's a really important point that we are not being told. So this is from that same study. And they found HPV status of the parents related to genital and oral HPV of the infant. The acquisition of high-risk HPV DNA by the infant in his or her oral or genital mucosa was related to the HPV status of the parents. And this is not from incest or sexual contact, because somebody who has an HPV infection can spread it to another person by touching their genital area, just as we do when we are changing diapers. And what this graph shows is that they measured the rates of detection of genital oral high-risk HPV DNA during the first 2 years of the baby's life. So at birth, it was present at delivery in a certain percentage, and it was still present at 24 months, so that 2-year period of time. So what we don't know is how long those children will continue to be HPV positive. And will they still be HPV positive when they receive the Gardasil vaccination at age 9 or 11 or 12 or 16? Going back to the VRB-PAC background document, the second concern was the observations of CIN2/3 or worse cases due to HPV types not contained in the vaccine. These cases of disease due to other HPV types have the potential to counter the efficacy results of Gardasil for the HPV types not contained in the vaccine. So when they were looking at this, they were looking at 4 types out of what we now know are more than 200. So that's a big concern. This is an article that was published in 2008. And in this article, where they were looking at different papillomaviruses in squamous intraepithelial cell lesions, so women who already had some changes in their cervix, and they had some procedures done to look at those cells and find out what particular types of HPV they had. Only 28.2% of women with CIN2 or CIN3 confirmed by biopsy were infected exclusively by HPV 16 or 18, a finding that places in doubt the degree of protection afforded by HPV vaccination. So we've gone from 16 and 18 cause 100% of cervical cancer lesions to it's about 70 and it's about 50, and in this study they found it was 28.2%. What's that? You know what? I don't have that off the top of my head, but, and I did not put a tiny URL down there. I apologize for that, but I will find that out. All right. So this is another study that was published in 2016. And are people familiar with the term viral shift? Okay, or antigenic replacement. That's another term that they use. Let me explain that first. Viral shift is something that happens when you have a partial coverage vaccine. It happens with viruses and it happens with bacteria. The Prevnar vaccine is a really good example of what happened with bacterial shift or antigenic replacement. The Prevnar vaccine, the first one, we know of Prevnar 7, and it contained 7 strains of Streptococcus bacteria. What happened was, once they started giving the Prevnar 7 vaccine, within the first 5 years of giving that vaccine, other strains, because Prevnar the Streptococcus, there are more than 100 strains of Streptococcus bacteria. So what happened was, when they started knocking out those strains that were the most prevalent and that were causing disease at that time, nature said, wait a minute, we're going to get the balance back here. So those other bacterial strains that had not been problematic beforehand started coming forward and causing more disease, causing more infections, more bacterial infections, more strep infections, and they were more resistant to antibiotic treatment. And we have the vaccine to thank for that. So what they did to fix that problem, temporarily, they band-aided it, and they created Prevnar 13. And they brought in more bacterial strains. And what the research shows now is that the same thing is happening again, and other strains are coming forward and causing more disease. So it is a never-ending cycle of nature trying to come back and mediate what man has mucked up. Okay, so in this study that was published in 2016, among the findings, HPV positive women aged 16 to 22 who were more likely to be protected against vaccine strains of HPV had increased rates of infection with other strains of high-risk HPV compared to older women who had not been vaccinated. So when they looked at the older women who did not receive the vaccine, or who were less likely to have received the vaccine, they had still the same kind of distribution of HPV strains. But then when they looked at the younger women, those viral replacement, that viral shift and that antigenic replacement is happening in the younger women. Evidence of increased virulence of HPV strains not included in the vaccines, with strains previously considered low-risk HPV now being classified as high-risk HPV. So the same thing is happening with Gardasil and the viruses as happened with Prevnar and the bacterial strains. Okay, so let's look at the clinical trials for Gardasil. This is a research article that they did a systematic review of, systematic search of literature to identify all randomized controlled trials of prophylactic HPV vaccination. Merck, the CDC, and many pediatricians claim that Gardasil is safe and effective at preventing cancer. So what does the evidence really show? That's a big table with a lot of little tiny characters on it. So I'm not going to attempt to explain this from there. But the title of it is Characteristics of 6 Randomized Controlled Trials and 3 Follow-Up Studies of Human Papillomavirus Vaccination Included in the Systematic Review. So this is one of the things, this is from that table. And I just wanted to highlight some of my concerns about this, looking at it as a researcher. The first issue is with the ethnic background. Study subjects were overwhelmingly white. Risk factors for chronic HPV infection include Hispanic or African American race. White women and those with higher socioeconomic status are the very women who are most likely to clear the virus on their own within 6 months to 2 years. So they heavily loaded the subject pool with white college students, which is not representative of those women who were least likely to clear the virus on their own. Does that make sense? Okay, and the second issue is the lifetime number of sexual partners. Participants were excluded if they had more than 6 sexual partners. In 3 of the studies, the median number of sexual partners was 2 or less. Risk factors for chronic HPV infection include higher number of lifetime sexual partners, women who have 6 or less partners, and certainly women who have had 2 or less partners are not among those who would be considered to be at highest risk or higher risk for long-term HPV infection. So they did what they always do. They loaded up their study with people that really weren't at risk for what they were studying in the first place, because that kind of gives them a lot more chance of finding what they want to find rather than necessarily finding the truth. Okay, so this is Table 1, Part 2, which is another very big table that we can't read from here. So I'm just going to go to the next one where I've blown it up. This is the third issue that I have with this, and this is the most important issue to me. There were no true control or placebo groups. 5 out of 6 of the placebo groups were given the adjuvant, aluminum, at 225 to 500 micrograms. The 6th study used another vaccine, the hepatitis A vaccine, as the placebo. The hepatitis A vaccine which was used was Havrix, and it contains 250 micrograms of aluminum. So you can see right there where I put that little red box around it, each one of those where it says placebo, 225 micrograms of aluminum adjuvant, 500 micrograms of aluminum hydroxide, 225 or 500 or 400 of aluminum. So you get the idea there, all of those. So there's when there is no true placebo, there's no true safety data. It doesn't exist. Now going back to that VRBPAC background document, when I look at that and I see this placebo stuff here, and then I go back to here, I'm reading this again. The Future 2 study, the sponsor, which is Merck, provided results for the phase 3 study. A randomized, this is a quote from Merck to the review group that's looking at their data. A randomized, worldwide, placebo-controlled, double-blind study. And down there it talks about the Future 2 study. So there's the Future 2 study right there. In that box right there, the placebo was 225 or 450 micrograms of aluminum. And, I mean, either they just took their word for it, or they don't know what a placebo is, the FDA. Or they don't read it, or whatever. But a placebo, for those who don't know, the definition is an inert or innocuous substance used especially in controlled experiments testing the efficacy of another substance, such as a drug. And anyone who has been here at this conference and heard about aluminum or aluminium from Dr. Chris Exley can stand up and testify right here in front of God and everybody that aluminum is not an inert substance, right? So it cannot be. Aluminum cannot be a placebo. The aluminum adjuvant is put in the vaccine in the first place to stimulate the immune system and cause an inflammatory response. How in the world can that be a placebo? It can't. All right, so this is from Merck's manufacturer's insert for Gardasil, that 28-page book here. On page 7, it talks about deaths in the entire study population. Across the clinical studies, 40 deaths, 21 in the Gardasil group and 19 in the placebo group, were reported out of 29,323 subjects. And these were age 9 through 45 years old, girls and women, and 9 through 26-year-old boys and men. 29,323 divided by 40 is 733. That's a death rate of 1 in 733 in the subjects from the clinical trials of Gardasil. And these were young, healthy adolescents and adults who had been screened before they were accepted as subjects. They were screened for pre-existing conditions. That death rate is, I haven't found the exact number, but I've heard people say 10 to 20 times higher than what the normal death rate would be for that age group. I don't know any place where young, healthy adolescents and adults are dropping dead at a rate of 1 in 733. Now, in the Gardasil manufacturer's insert, it does talk about a saline placebo group of 594. There were no deaths in that group of that actual saline placebo. So if you remove those 594, the death rate goes to 1 in 718. All right, this is also, now I want to go back to here. The events reported were consistent with events expected in healthy adolescents and adult populations. And then it says the most common cause of death was motor vehicle accident. There were 5 in the Gardasil group and 4 in the aluminum group, followed by drug overdose and suicide. And gunshot, there were 2 individuals with the Gardasil group and 6 individuals who received the aluminum group for drug overdose and suicide. And then gunshot wound, 1 individual who received Gardasil and 3 individuals who received the aluminum control. Okay, so people argue with me online when I talk about this death, and the common thing that I hear is, okay, so Gardasil causes car accidents, right? Yeah. Well, from the insert, the number 1 warning and precaution is syncope. For those who don't know what syncope is, it is a sudden loss of consciousness. Seizures are also mentioned there, tonic-clonic movements, syncope, loss of consciousness, and tonic-clonic movements. Okay, seizures. So who are we giving this vaccine to? Teenagers and young adults who are driving cars. And when you have a seizure or a syncopal episode while you are driving a car, you can have an accident. And you can kill not only yourself, but somebody else. The The other thing that I get talked about, and having recently been through some health issues with complex regional pain syndrome, I can tell you what really severe pain feels like and what it feels like when you have no hope, which is not me, but at one point, because they say, well, there's nothing we can do, we can't figure this out, blah, blah, blah. Okay, so if you look at the Gardasil girls and at the videos of these young adults who have been so severely injured and are in such pain, it is extremely easy to understand why the rates of suicide would be high in this group. So, yeah, Gardasil can cause suicide, and Gardasil can cause car accidents. Now, this is from the manufacturer's insert for Gardasil 9. And what I want you to see here is that the safety of Gardasil 9 was evaluated with Gardasil as the control. Because we all know Gardasil is safe, so therefore we're just going to give Gardasil 9 and Gardasil, and that'll be our control, and then we'll see if they're any different. Now, this is also something that is routinely done with vaccines. It was done with the DPT and the DTaP, because they had to make a new vaccine because DPT was so dangerous. So when they made the acellular DTaP vaccine, they compared it with the DPT, and they said, well, there's no more serious adverse events, no more deaths in the DTaP as compared to the DPT, so therefore it's safe. When the whole reason they created the second one in the first place was because the first one was so dangerous. Okay. This is also from Gardasil 9. Oh, let me go back to this really quickly, because I talked about not a coincidence. The reason that they use that term for not a coincidence for the Gardasil video from Canary Party, what they said in the write-up from this data from Gardasil is that the reason that these deaths would have happened by accident or by coincidence, because there was no significant difference between between the experimental group and the placebo group. But they were reacting to the aluminum in the placebo group. So that's why it's not a coincidence, because this is not a coincidence. Okay. Now this is from Gardasil 9. Systemic autoimmune disorders. In total, 2.2% of Gardasil 9 recipients and 3.3% of Gardasil recipients reported new medical conditions potentially indicative of systemic autoimmune disorders. And they tell us serious adverse events are 1 in a million. So going back to my percent calculator, 2.2% of 1 million is 22,000. And 3.3% of 1 million is 33 in 1 million, 33,000. So it's not 1 in a million. It's between 22,000 and 33,000 in a million. So what does that look like for one birth cohort in the United States? There are approximately 4 million children born every year in the United States. So let's say we vaccinate every 11-year-old in the United States for Gardasil. Depending on if we use Gardasil or Gardasil 9, we could expect 88,000 to 132,000 new autoimmune diseases. And that's in one birth cohort. How can they continue to deny the damage when they found it in their own clinical trials? This is the latest data from VAERS, Vaccine Adverse Events Reporting System, as of July 14th, 2017. There were 14,606 emergency room visits, 6,927 serious adverse events, 4,852 hospitalizations, 2,011 patients disabled, 834 life-threatening reactions, and 328 deaths reported. And if you don't know, I'll tell you. It's estimated that less than 10% of adverse reactions is reported to VAERS, and the number is probably between 1 and 2%. This is a graph put out by a website called SaneVax, which is a great place to go for information about Gardasil, sanevax.org. This graph shows HPV versus all other 13 recommended vaccines for the age group 7 to 18 in the United States. I snagged this from one of Suzanne's videos because I couldn't find it without doing it from her video, so that's why it's got the lines there. But the maroon bars are the HPV vaccines, Gardasil and Cervarix, and the blue bars are all other vaccines combined that are recommended for 7 to 18-year-olds. And you look at, I don't know if you can see the writing there, but abortions, which is miscarriages, chlamydia, infertility, that third one, look how high that maroon bar is. That's just for, the maroon bar is just for HPV vaccines. That little blue bar right there is for all other vaccines combined. And then come over to disabled. Gardasil has the highest amount of serious adverse events by far of any vaccine, and compared to all other vaccines combined, it's still higher. If this were equal, the Gardasil, the maroon lines would be down to 1/13 of the blue lines. This is from SaneVax, and I'm running a little bit low on time, but I want to just include this. This is an article put out by SaneVax. They sent off samples of Gardasil. They sent 13 samples of Gardasil to be evaluated, and they found evidence of contaminated HPV DNA in every single sample of the vaccines. And the questions surrounding that are huge. We don't know what that's going to do. We don't know what the ramifications of that are. We don't know. Does that mean that it is going to, that people who are injected with Gardasil and who have this contamination, are they going to become infectious to other people? We don't know. Lots of questions about that. And you can find that, and I would recommend reading that information on SaneVax. This is where you can get some really good information about the reactions and what they really look like. Dr. Suzanne has done some amazing interviews with Polly on the Vax tour, and if you go to tinyurl.com/VaxTV Gardasil, there are when I did it today, it was more than 4,000 results. So there's a lot of stuff there that you can look at and see what this really looks like for people. Now, this is from Colombia. There's been a class action lawsuit against Gardasil vaccine filed there on behalf of more than 700 girls and women whose health has been negatively affected by Gardasil. 700. And they got a class action lawsuit going. And this is from Japan in 2013. Around 2,000 reported side effects caused them to pull their recommendation for Gardasil in Japan. Why isn't the United States government looking into the problems with Gardasil and Gardasil 9? Well, we all know probably that the 1986 law prevents us from suing, right? So we can't sue Merck. But there's something else. Remember those VLPs, those virus-like particles? Who invented the VLP cervical cancer vaccines? Well, if you ask patent offices, the answer is anything but simple. The U.S. Patent Office recognized 4 claimants to the basic technology: the National Cancer Institute, Georgetown, Queensland, and Rochester. So the National Cancer Institute is part of the National Institutes of Health, which is a United States government agency, and they invented the VLPs. And then they licensed them to Merck, and they became business partners. And there's another one there about the new HPV commercial, that one that's shaming and blaming parents, right? Merck's new ad, Shaming and Blaming Parents, first aired on June 28, 2016, running on all major networks, including during the Summer Olympics, maximizing the impact of its advertising dollars. And it paid off, because Merck beat the estimates of sales, as the sales of Gardasil vaccine surged. The cost of Gardasil 9 for use in the private sector is currently $204, almost $205 per dose. So if you're given 2 doses, that's $410. If you're given 3 doses, that's $615 per child. Gardasil is currently ranked the second most profitable vaccine in the world, with projected sales at $2.5 billion by 2020. And remember, Merck is not the only one benefiting from this surge in sales. The United States government also benefits financially from the sale of Gardasil. Could this be a factor in why our elected officials and their agencies are turning a blind eye? All right, recap. Lots here, so I am going to read. There are more than 200 types of HPV. Nearly everyone is infected with HPV at some time of their life. 95% clear the infection spontaneously within 1 to 2 years. Routine Pap screens reduced the incidence of cervical cancer in the U.S. by 74% prior to the invention of the HPV vaccines. Cervical cancer is a slow-growing cancer with nearly 100% recovery rate with timely diagnosis and treatment. Gardasil 9 is the current vaccine used in the United States and most other countries around the world. Gardasil 9 targets only 9 strains of HPV. 7 are considered high risk, 2 are considered low risk. Gardasil 9 was developed because of antigenic replacement or viral shift because Gardasil quadrivalent only covered 4 strains. There are many other high-risk HPV strains that are not covered in Gardasil 9. HPV can be passed from mother and father to infants. It's not just a sexually transmitted infection. Those infected with HPV prior to receiving Gardasil vaccine are at 44.6% increased risk of developing precancerous lesions. There has been no effort to test children to see if they are already HPV positive prior to administration of the Gardasil vaccine. There is no true safety data for either Gardasil or Gardasil 9. Clinical trials use either aluminum adjuvant or another vaccine as the placebo. Gardasil 9 was approved on the basis of Gardasil being considered generally regarded as safe. In the original clinical trials for Gardasil, the death rate among subjects was 1 in 733. In the clinical trials for Gardasil 9, the rate of new autoimmune disease was 2.2%. Serious adverse events reported to VAERS for HPV vaccines are higher than serious adverse events reported for all other recommended childhood vaccines combined, I should say for the ages of 7 to 18, with infertility and disability among the most frequently reported outcomes. While other countries have responded with lawsuits and removal of recommendations after increasing reports of serious adverse reactions to Gardasil, the United States continues to push for increased uptake of the vaccine. The United States government, via the National Cancer Institute and NIH, is a business partner of Merck and benefits financially from the sale and uptake of Gardasil. So where's the good news? We are not helpless. There are things we can do to protect ourselves and our children. Ways to avoid cervical cancer, according to the published medical literature, include, and I have to say this, delay coital debut. And I have to say it that way because it makes me feel very Sheldon-esque. So basically what that means is don't have sex until you're a little bit older. Minimize the number of partners when one does become sexually active. Practice consistent and correct condom use every time. This is important. And the reason it is so important is because, here's 2 things. HPV is not a discharge disease. That means it's not like chlamydia, and it's not like trichomonas, it's not like gonorrhea. Those are discharge diseases. But if you have one of those discharge diseases, it greatly increases your risk for chronic HPV infection. So using condoms consistently and correctly really helps with preventing those discharge diseases, those discharge STDs. Condom use is not as protective against HPV because HPV can be spread skin to skin. But it's still important to use those condoms. Don't smoke cigarettes. That's a huge deal. It's a factor that always comes up in the literature. Eat a healthy diet rich in nutrient-dense foods. Ensure optimal levels of folate and antioxidants, especially vitamins A, C, E, and selenium. Routine pap smears beginning at age 21 and continuing throughout the lifespan reduced the incidence of cervical cancer by 74% in American women before HPV vaccines were invented. So what else can we do to guard against cervical cancer? Protect the vaginal microbiome. This is really new research, and it's very important research. This is from April of 2017, and I'm just going to, the link down there, tinyurl.com/vagmicrobiome-HPV. If you go there, this article has a lot of information about the use of prebiotics and probiotics. It also illustrates how important it is, and we should all know this, right? We're here about the environment and toxins. We want to have a healthy cervix. We need to have a healthy vaginal microbiome. That's our internal environment. So things like being really careful about overuse of antibiotics, taking your probiotics, making sure you're getting really good probiotics and good strains of probiotics, and doing all of those other things, protecting that microbiome, eating fermented foods, Making sure that your gut microbiome is really good as well. Here's another one from 2016. That's a free article, and there's tinyurl.com vag microbiome CC for cervical cancer, finding the same thing. And another one from 2015, also finding the same thing, and the importance of the vaginal microbiome. These are things that we can do and that we can do with our kids, and we can help to protect them. All right, anything else we can do? Yes, and all of you are doing it. So just keep learning, keep reaching out and helping others to learn what you know. Build relationships with your legislators and educate them about the facts, because all they're getting is the fear. And all we're getting is the fear and guilt, but they're getting the fear. So if they don't hear from you, they don't know the facts. Join your local groups and register with nvicadvocacy.org to keep up with what's happening in your state. And that's what we can do. So thank you. No, I don't know if we have time for questions, if there are any. Yeah.
The other countries that have lawsuits, who are they suing, or whom are they suing?
In other countries, they can actually sue the vaccine manufacturers. They can sue Merck or GlaxoSmithKline, and that has happened in multiple other places. We don't have that option because of the 1986 law.
Okay, good. Thank you.
In regards to a healthy vaginal microbiome, are there any studies that relate toxic feminine care products to the destruction of the biome?
That's a very good question, and one of the things that I recall reading, and I'm sure there are, I was concerned about time, but this is the next level of where I'm going to go with that. But one of the things that I recall reading is that one of the reasons that's postulated why African American women tend to have higher rates of cervical cancer is because they douche more. They use more products off the shelf for douching, and that irritates the lining of the vaginal environment. I have not seen that, but I would be absolutely floored if there isn't any evidence about it. I mean, things like glyphosate in tampons and that sort of thing. Another thing that just came to mind here is that, and I have to thank my good friend Curtis Duncan in Atlanta for this. It might be a little bit inappropriate, but who cares, right? So we're talking about vaginas and stuff like that. But he talks about the damage that is caused by plastics in sex toys and in dildos and that sort of thing, and how the vagina is just like a sponge and it absorbs everything. So all of those things could certainly be factors.
Right. Even the spermicides and the...
Right. Yep.
Yeah. Okay.
Yes.
Interesting. Thank you.
Yeah. Thank you for that question. You gave me something else to think about. Yes.
So I'll just add a note that there are phthalate-free toys. I'm not going to say how I know.
Good. There are phthalate-free toys for anyone who's interested.
Yes. My question is, I saw online on your screen that it said get pap smears at the age of 21. So I was texting some good information to a friend whose daughter had a couple of the shots, and I'm trying to help her through not getting the third and give her good information. And she said, well, why not 18? The doctor's pushing for 18. Can you give a good answer for the difference?
I do not have a good answer for that, other than I think there was the age of 21, and Diane Harper's recommendation for the age of 21 is based on the fact that HPV related changes in the cervix occur over time, over a period of time. And so depending on when her daughter became sexually active, or if she is sexually active and how old, that is going to influence it. But if she's had 2 Gardasil vaccines already, I would say go ahead and do it earlier, because you don't know what the effect of the Gardasil vaccine has been.
Giving the wonderful disease. Yes. Thank you so much.
Right. Yeah. Thank you. I'm going to close this. Okay. All right. Thank you very much.